Okay, seeing that it's noon, we'll go ahead and get started for today. Thank you everyone for joining us. I'm Brooke Barnes with the Scott County Health Department. On behalf of the Scott and Rock Island County Health Departments, thank you for joining us on today's webinar on the COVID-19 vaccines with Dr. Lewis Katz. Advance a slide here. Before Dr. Katz begins his presentation, we wanted to provide you an update on the public messaging that's taking place on vaccination in our community, along with the information you'll be hearing today. The Quad Cities COVID-19 Coalition, which is a collaboration of area healthcare, public health, government, business, and nonprofit partners, does have the Together QC website and is updating it regularly with information, and now includes a page on the COVID-19 vaccine. Similar information can be found on both of our health departments' websites, and they provide links to frequently asked questions pages on the state health department sites, as well as the CDC. Communication staff from both health departments, both hospital systems, community healthcare, and other partners are beginning a public messaging campaign to educate members of the public on the vaccine basics. This will include things such as vaccine development, availability, safety and side effects, and benefits of the vaccine in slowing the pandemic. Our messaging will also encourage individuals to ask questions about the vaccine if they have them and get answers from credible sources such as sites with research from subject matter experts and also from healthcare professionals such as yourselves. For your patients wishing for additional information on the vaccine, we encourage you to direct them to our health department's websites and the togetherqc.com website for specific information to our community. In Scott County, we will continue to provide updates on the pandemic to medical providers through a listserv. If you are not yet on the listserv but would like to be added to receive county-specific information on CDC guidance, as well as future vaccine recommendations, please type your email into the chat box and we will get you added to the list, or you may contact the Scott County Health Department and we will add you that way as well. As always, thank you for your continued partnership in responding to this pandemic. We know you and your staff are bearing a large burden of the pandemic at this time, and there's no adequate way to share our gratitude. We continue to be grateful for your partnership and support. Without further ado, I will introduce Dr. Lewis Katz, Infectious Disease and Internal Medicine Specialist and Medical Director of the Scott County Health Department. As I'm stopping my screen share here, Dr. Katz, I'll let you get your screen going. If you do have questions for Dr. Katz, please type them into the chat and we will get to the question and answer section once he is finished with his presentation. So Dr. Katz, you should be ready to share and get started.
Okay, you got it, Brooke?
Yes, it looks good, thank you.
And you can hear me?
Correct.
Well, I just went through who's on the webcast. I don't know any of you. I've been in the Quad Cities since the early 80s. And I was the first ID doc in the Quad Cities, set up the virology center that Bharat Matwani now manages, and was hospital epidemiologist at Genesis, as well as medical director at the health department and chief medical officer at the blood center. And a lot of what I've done over these last 40 or so years informs what I'm thinking about vaccines now, as I'll tell you. So you should be seeing our epi curve that I updated this morning. And as you can see, we're dealing with extreme uncontrolled community transmission and expect surges within the surge as we get another 5 or 6 days away from Thanksgiving and then into the Christmas and New Year's holidays. Current rates are on the slide. I get comfortable with kind of normal activities at a rate of 5 per 100,000 per day and at a test positive rate below 5. So as you can see, we're really in a world of hurt right now. And for some reason, I can't make my slides move. Give me a second, I'll figure it out. There we go. This is key resource use, and you folks that are actually taking care of sick people these days are probably more familiar than I am. This is the Iowa Region 5, that's the blue area. in the lower right of the map. And so you can see the number of inpatients, the number in the ICUs, the number being admitted in the prior 24 hours has spiked along with our case counts with the appropriate time lags. As of yesterday morning, in Region 5, there were 76 patients on ventilators and 184 ICU beds available in that southeast corner of Iowa. So I guess so far so good. Capacity is maintained, and if things continue to drop off, we'll be okay. I don't expect that to be the case, and suspect over the next week or so, we're going to start to get in more serious trouble again. These are the vaccine candidates that we're all interested in. These are the, how many is there? There's 6 or 7 that Operation Warp Speed is supporting. The 4 on the bottom you can forget about for the medium term. They're just not ready for prime time. The 3 on the top are the ones that are getting all the media attention. The 2 mRNA vaccines and AstraZeneca Oxford use adenovirus vectored vaccine. I'm really only going to talk about the first 2 because I think AstraZeneca is going to be on hold for a while things get sorted out. The first 2, Moderna and BioNTech Pfizer, have filed their emergency use authorization applications with FDA. The vaccines and related biologic products advisory committees will meet on the 10th and the 17th of this month to discuss those 2. AstraZeneca has a lot of questions to answer and won't file for quite some time. My crystal ball suggests that Moderna and Pfizer BioNTech will get emergency use authorization rapidly after the VRBPAC meetings that I have referred to. Here's a kind of a rhetorical question. How many press releases does it take to make data? Media reports are not data. And with a special regard to AstraZeneca, they made a dosing error in their phase 3 study that has had rather substantial effects on the outcome, and that all needs to be sorted out. But Moderna and BioNTech, Pfizer, are in that 90 to 95% efficacy against clinical infection area, much better than any of us had ever hoped for. And in addition, again, based on media releases, largely prevented severe disease that would wind people up in the ICU. If an EUA is granted for for both mRNA vaccines, CDC is estimating in the range of 40 million doses available by the end of December or early January. So 40 million doses is 20 million courses. That's an important number as we get a little further into the talk. One of the biggest questions I'm getting now is how are we going to know if these vaccines are safe? We're dealing with press releases regarding 2 months of follow-up from the phase 3 trials, in aggregate somewhere in the range of 70 or so thousand vaccine recipients. So 2 months of data is very short for a vaccine approval, but this is a unique set of events. I'm not going to go through this slide in great detail, but these are the individual systems that are either existing or being rapidly implemented as we speak to do safety surveillance following an EUA. The pediatricians and family docs on the call will be very familiar with VAERS, Vaccine Adverse Event Reporting System, that they're already putting into if they're doing any number of pediatric immunizations. The others that I want to talk about are on the right-hand side of the slide, and particularly VSafe at CDC, that over the next couple of weeks I expect you to hear a lot more about. This is a smartphone-based text system that vaccine recipients need to register for, and they will get very specific prompts from CDC to talk about adverse effects from vaccines. So it's active surveillance to the degree that you can convince the people that you vaccinate and talk to sign up for it. BEST is an FDA project that, along with Genesis, that's a new one, a collaboration of NIH and Brown University, that leverage big data from electronic health records and should be very useful. And of course, the manufacturers have agreed with FDA to a 2-year follow-up of their phase 3 participants. It looks like a Rube Goldberg machine, but I'm confident we're going to have enough data to feel very comfortable. Please be aware that it would be unprecedented for serious adverse events to show up beyond 2 months. It just has never happened, but it doesn't mean it won't. And so surveillance has to be very persistent so that we know about that. This is a nice piece on the upper left from Science last week, I think. Basically, the data on adverse events are really skeletal at this point, coming as they do from media releases. The companies define adverse drug events or adverse vaccine events, severe adverse vaccine events, as those that result in interruption of activities of daily living. Here are the data that I could piece together on the 2 mRNA vaccines. And as you can see, it isn't much. But I would agree with the Science reporter that it is absolutely critical that you talk to your patients carefully about these issues. There's going to be, under EUA, a lot of written fact sheets available in 5 languages, coming from CDC and the FDA and on and on and on. But I think the important question is who reads that stuff. I'm a veteran of a substantial number of clinical trials, and I'm convinced that it's a fraction of the people that need to read those sorts of documents do so. So you need to brief your patients as they get immunized about what we know after the data are presented at the Burbank meetings. And we will make that data available through many venues as it becomes available. Transparency about adverse effects is critically important. If we define an adverse effect as interrupting ADLs, and you have, let's say, an ICU where you do mass vaccination of the staff in the ICU over a period of a day or so, and 10 or 11% are feeling crappy the next day and don't show up for work, what have you accomplished? So we need to pay very close attention to this. Vaccine recipients need to know what to expect and what to do about these sorts of events when they occur, and people planning vaccination in particularly healthcare venues need to be aware that there could be staffing concerns as large numbers of people are immunized very, very rapidly. The next slide shows you, this is the COVID vaccine approval, but it's actually the vaccine approval process at FDA for anything. Phase 1, phase 2, phase 3, phase 3 being the big trials, thousands of patients looking for efficacy and safety signals. EUA is not usual for a vaccine. It's going to be important for COVID because of the public health emergency. After phase 3, with or without an EUA, comes approval decisions, that is the full approval for the vaccine, and then phase 4 studies, which are essentially post-marketing surveillance, where we extend our follow-up out for long periods of time to be sure we haven't missed rare important events. The Vaccine Data Safety Monitoring Board for the Warp Speed vaccines is independent of HHS. This is not an HHS committee. They report to HHS, but it's not an HHS committee. There are no political appointees. It's subject matter experts. The only individual at FDA that's a political appointment is the commissioner, and I'll touch on that a little bit later. And the Vaccine and Related Biologics Products Advisory Committee is an unpaid panel that advises FDA, and it's composed of subject matter experts and consumer representatives. This is the National Academy of Sciences, Engineering, and Medicine Vaccine Priority Framework in brief. It's actually an 80 or 90-page document that is available to you free online that goes into all the rationales.
Dr. Katz, we just lost your audio. Dr. Katz, can you hear me? We just lost your audio.
Advisory Committee on Immunization Practices. They voted on phase 1A only. Phase 1B and phase 1C are proposals for discussion and will be the subject of repeated meetings over a short period of time of the ACIP. So phase 1 is healthcare workers, and I'll show you the definition, and long-term care residents. This was approved 13-1 by the ACIP yesterday about 5 o'clock in the afternoon Central Time. As we move through phase 1A and get the maximum number of people in these groups vaccinated that will accept vaccine, we'll move into phase 1B, essential workers, however that ends up being defined at the end, and then again into phase 1C, and then phases 2 and 3 and 4 if there is one. I'm guessing that to get to general availability for the entire population will be very late second quarter or into the third quarter next year. I hope I'm wrong. I hope it's faster than that, but I'm not terribly optimistic. So here are the definitions of the 1A groups. Healthcare personnel are as defined on the left, and these are not prioritized. These are all at the same priority. So hospital direct care personnel, long-term care facility staff, outpatient venues, home health care, pharmacies, EMS, first responders, and public health. I think very straightforward. And it's about 21 million individuals in the United States. Long-term care residents are in fact prioritized. There are 3 million in total. Skilled nursing, assisted living, other residential care. That's in order of priority. So we'll try and get skilled nursing facilities first, followed by assisted living, followed by residential care. Totally dependent on how much vaccine is available, how much is allotted to Iowa, and what our priorities end up being within these parameters in Scott County. What are the barriers and unknowns and black holes that we're dealing with? The barriers are I think, pretty obvious if you've been reading the literature at all. Dominated by, number one, the rapid rollout. So we're building an airplane while we fly it to get these vaccines into people's arms. The Pfizer vaccine has to be stored ultra cold. We have enough ultra cold storage capacity in Scott and Rock Island counties, certainly to handle 1A, and I think all of phase 1. The Moderna vaccine is just frozen, so that should not be a problem. And then the major barrier is totally operational. It's a 2-dose series. So you have to get your healthcare workers back for the second dose, and you have to deal with turnover in long-term care facilities where somebody has come in and gotten their first dose, and now they're someplace else when it's time 3 to 4 weeks later for their second dose. We have no data, none, on the duration of immunity, the need for booster shots, the impact of co-administration with other vaccines, especially flu and pneumococcal vaccine, the safety and efficacy in pregnancy and breastfeeding women, and on and on and on if you want to pick subgroups that might be of interest. There are really very few data in long-term care on the efficacy or safety for the residents. There are a lot of elderly in the clinical trials, but they're community-based well. And this was the genesis of the single no vote on ACIP, is this lack of data and then going ahead and making a recommendation to use the vaccine on several millions of those people. Had I been a voting member on the ACIP, it might have been 13-2. I'm very ambivalent. I believe it's going to be safe. I don't know about effectiveness. The number of doses that will be consumed is not overwhelming. So I would really have been on the fence about this. I think it will become available, vaccines will become available within days following a recommendation by VRBPAC to the agency, to FDA. So that first meeting is the 10th, the second on the 17th. So I think we'll be putting vaccine into arms late the week of the 10th to 17th and subsequently. So we'll be up and running in mid-December, I'm pretty confident. I've told you who the 1A people are, and then the main question about who is what role vaccine hesitancy will take in our ability to immunize large numbers of people, particularly as availability expands. Here's a survey that was published last month in Science. And the bottom line here, I think, is very self-explanatory and straightforward. Half of the overall population is hesitant to receive the vaccine. My personal opinion is that this will improve fairly rapidly if our rollout is successful and we get support for immunization from individuals' personal providers. So you need to tell your patients that you support this vaccine. If you don't support this vaccine, assuming the data don't change, you need to talk to me because I am very confident that these are going to be safe and effective within what we know to date. I get this question all the time, and my answer is pretty emphatic, I think. The data assumptions are transparent, and I will be on both of the VRBPAC meetings, listening very carefully to the data and listening very carefully for anything that might be a new safety concern. I have a number of colleagues and acquaintances at CDC and a couple on the ACIP and at FDA in the Center for Biologics Evaluation and Research. And I can't get details from them, but they are all telling me there will be no surprises. That, you know, that's for what it's worth. Maybe more importantly than reviewing the data is my trust based on 40 years of personal and professional involvement with the Center for Biologics at the FDA, the center that is responsible for vaccine evaluation and approval. When I looked at who's on the call, there was nobody I know. I spent 8 years in Washington at one of the national blood organizations as their chief medical officer and was in contact essentially daily with the leadership of CBER. Before that time, during my career at Mississippi Valley, I interacted repeatedly with FDA on a number of operational and scientific issues. I had 2 terms on the Blood Products Advisory Committee, the sister committee of the VRBAC, including a term as chair. So my understanding of the function and independence of the approval processes at FDA is informed by decades of experience. Further, the leadership at CBER, including the director of CBER, Dr. Peter Marks, is a good friend and colleague with whom I have had extended conversations over the last 6 to 9 months about events at FDA surrounding COVID, including the ill-advised emergency use authorizations for hydroxychloroquine and convalescent plasma. And I accept his word without question at this point that the commissioner of the FDA has learned his lesson and that there is no political pressure on CBER with regards to either EUA or approval, and that CBER is 100% committed to science and medicine, not politics, in this decision making. So, once again, to reiterate, the first day it is available to me, I will get it. And the first day it is available to my wife and kids, they will receive it. Now, I want to move on a little bit to something that people need to pay close attention to. And that is that as we roll out vaccine, it really doesn't change anything in terms of the non-pharmaceutical interventions that we're recommending at this point. I'm not going to dwell on the specific date on this slide because it better be old hat to you folks. If you don't understand this, I have great concerns. But the bottom line is that we can't tell who is transmitting SARS-CoV-2 in the ways that we always have with other respiratory pathogens like influenza A, SARS, and the Mideast Respiratory Syndrome coronavirus. They are transmitted by symptomatic people, and it's easy to use syndromic surveillance and get control of outbreaks compared to SARS-CoV-2, COVID-19. So we need to continue universal source control, recognizing the vaccine rollout will take 9 months or a year to even approach herd immunity, if that is possible, given the unknowns about duration of immunity, protection from transmission by immunization, and how much vaccine uptake we'll see. So the critical message to you in the community is there will be no relaxation of NPIs at best through the first half of 2021 at best. Masks, physical and social distancing will need to improve markedly from our current compliance, or morbidity and mortality will continue to accrue at rates that are frankly unsustainable with all their indirect and direct effects on our lives. So I want to briefly re-emphasize some things about those non-pharmaceutical indications. This is 2 MMWRs that you all should access online as soon as you get off this webcast and review. Nothing magic here, and these are just studies that confirm everything that we've been hearing from all over the world and all over the country since the spring. They're quite dramatic, and I think you should read them. Kansas was a natural experiment where the governor finally allowed individual county jurisdictions to mandate masks in public. Well, some did, some counties did, and some didn't. And the difference between the counties that did and didn't was dramatic. This occurred during the summer surge in Kansas. Rates increased by 100% in non-mandate counties and actually fell during the surge in the mandate counties. It's not a controlled experiment, but you don't need a controlled experiment. It's very dramatic. The lower right-hand side is the impact of non-pharmaceutical interventions in Arizona. And once again, in a temporal sequence appropriate to what we know about incubation periods for the virus, there is a temporal association repeatedly between implementation of NPIs and control of transmission. And that is even without draconian enforcement of the sort that was seen, for example, in China in January and February. The data in the text is from a Delaware study, also in MMWR, very similar, that demonstrated state-mandated mitigation efforts, routine public health interventions, social distancing, physical distancing, masks, staying home when you're ill, and hand hygiene resulted temporally in falls in in cases, hospitalizations, and deaths, as you see there. You need to be public and vocal advocates for these measures. You need to work diligently as public health officials to counter the misinformation spread that is unfortunately coming from the highest levels of authority. We have a lot of room, a lot of ground to make up. This is my favorite single study. This is in Springfield, Missouri. And it's two symptomatic hairstylists in a salon who were symptomatic for 2 weeks with laboratory documented COVID-19, who had 139 clients, quote unquote, exposed between them. Both the stylists and the clients wore masks per company policy. There were no symptomatic secondary cases, and of those who submitted to PCR screening, 0 of 67 from the 139 were positive. It's not a controlled study, but it's pretty dramatic. And so the people who say masks don't work, you need to point these kinds of data out. I won't get into whether there's a constitutional right to infect other people by not following the non-pharmaceutical interventions that we're talking about. I will point out that it is, for example, illegal to shoot somebody on Fifth Avenue. And I consider the two essentially the same form of assault with a deadly weapon. So I'm done, and we can do Q&A if there are any. Oh, I had one more slide that I forgot about. This is a recent set of events this summer in Maine. It's a wedding. 55 people at the wedding, 2 people who had symptoms of COVID. The wedding reception exceeded the maximum capacity guidelines, and the attendees neither masked nor distanced. 27 cases and a death in the local community where the reception was held. 38 cases and 6 deaths in a long-term care facility where one of the infected attendees worked, and 82 cases in a correctional facility where another of the attendees worked. So you ignore common sense and people die. That's the message that I think people need to understand. Okay, Brooke, you want to move to Q&A?
Yes, I think just 2 quick questions here for you. Is there any formal recommendation for pregnant women to receive or not receive either of the COVID vaccines? I understand pregnant women were not included in the study, but any physiologically, should there be any additional concern?
Well, yeah, you know, there was extensive discussion on this on the ACIP call yesterday. And in the absence of data, both the FDA and the CDC are going to be very, very reluctant, I think, to recommend vaccination for pregnant women. Let me just say that we know that breastfeeding during active COVID, symptomatic COVID, is safe. So I would feel free to give it to breastfeeding healthcare workers during 1A. Pregnant healthcare workers, I think you're going to do a risk-benefit calculation and it's going to be in the absence of any data. This is not a replicating vaccine. There's no virus replicating with these two mRNA vaccines. The mRNA is taken up into probably myocytes when given intramuscularly, where the mRNA inside the lipid nanoparticle is translated into spike protein and results in an immune response. Why should that be dangerous in pregnancy? I think if my wife was a nurse in an ICU and pregnant and asked me, should I take the vaccine, I would probably recommend it. But I do not believe we'll see that recommendation immediately from FDA or CDC, and they'll probably use some legalistic language about doing a risk-benefit assessment.
Dr. Katz, another question. What would you recommend if an employee of a municipal or government employed EMS crew, fire department, healthcare worker consistently spreads false information about COVID on social media? I'm assuming this is through a personal account.
Well, you have to document it, and then you have to look at your HR rules. And if your HR rules are silent, it can be very difficult. At that point, I think what you do is warn the person that whoever it is with HR involved considers it a violation of the employment agreement and that they have to cease and desist. It can be hard if you don't have something already in your HR regs, HR rules that address that kind of behavior outside the workplace. It's a very ticklish thing. If this was happening at the health department, I would run upstairs to the 6th floor to the HR department with the director of the health department, and we would figure out a way to deal with it if it was all legally possible.
Okay, before we conclude today, I don't see any additional questions. We do have Amy Thorson here from the Scott County Health Department, who is going to give just a broad overview of some of the planning that's taking place for a vaccine as it slowly is going to begin making its way into the community. So I'll let her give you an update here.
Good afternoon, and thanks for making time to be on this call today. We know that there's a lot of excitement and anticipation and hope around this vaccine as we are all COVID weary. But we want you to know that this isn't an automatic fix. It's going to take some time. I know Dr. Katz has been talking a lot about the vaccine, and we know that supplies will eventually be very adequate to meet the demand, but that's not going to be the case in the early days. There is a group that is planning for initial vaccination clinics. That group involves, in Scott County, that involves Scott County Health Department, Scott County Emergency Management, Genesis Health System, Community Healthcare, and Unity Point Trinity, because we know that none of us can do this alone. So we are working on how we will be able to vaccinate the various priority groups. We know ACIP met yesterday, but we are still waiting for official recommendations from the state. And so that process and who will be number one is still being finalized here for Iowa. We are planning for more centralized clinics for the non-hospital-based employees. In the past, H1N1 would be the most recent. We did have the ability to go to more clinic-specific locations and vaccinate employees. With this situation, the need to get information and vaccine into people quickly makes all those individual stops much less efficient. There's also considerable storage and handling requirements as you're transporting this vaccine, particularly the ultra cold vaccine. And so we are working on plans for those centralized clinic locations. And as we know the who and how much we're going to have, we will be directly communicating with you the when, the where, and and how of this process. So we really understand that there are lots of questions. We have many of those questions too, and just appreciate your support. We do know that allocations to Scott County will come to, will be notified into the health department through the immunization registry regarding how much vaccine Scott County as a community, not a department, is eligible for. We then will be able to make allocations to providers that have approved CDC and Iowa Department of Public Health vaccine agreements in place. Those vaccine agreements detail what the expectations are for giving the vaccine as well as storing the vaccine. So for example, the Pfizer vaccine that requires ultra cold storage, there are only 2 agencies in our community that are approved to receive that vaccine directly. So we will be going through that process of allocating, involving partner discussions, involving Dr. Katz in those discussions, and try to get a vaccine out as efficiently as possible to approved providers. If you have questions regarding that provider agreement or you don't have one in place, if you go to the Iowa Department of Public Health's information, there is information there regarding how to establish a provider agreement.
Dr. Katz, we do have 2 additional questions that have come in here, and perhaps you and Amy can answer this first question. I'm concerned that we may not have second vaccine doses and we cannot save a second dose for recipients. Is that a concern that we currently have?
What we heard yesterday on the Iowa Department of Public Health local public health call is that the CDC is reserving second doses. So for every first dose allocated to Iowa, they're planning for that second dose.
And Dr. Katz, can you speak to the efficacy after the first dose and what we know just about immunity from the vaccine so far?
Well, I showed you the press release data, which is really what's available. Over 90% effectiveness against clinical disease, including severe disease. So that's wonderful. That's all after 2 doses. There will be data from the phase 3 trials after the second dose, but it's not yet available after the first dose, excuse me. It's just not available yet. So we don't know what happens if somebody gets their first dose and doesn't show for their second, whether and to what degree they're protected. Antibody levels and a variety of in vitro markers, I'm sure will be discussed on the Verback calls on the 10th and the 17th. So stay tuned, and I suspect you'll hear about it on CNN before I make a slide about it. I see a pediatric question as well. I believe the youngest immunized individuals in the 2 phase 3 trials were 16. So there's very little data in younger age groups. By the time we're past phase 1A into phase 1B and 1C, I believe there will be some pediatric data. It will not be as robust as what we see for adults. And I think you're all aware that in aggregate, kids are much less likely to have serious morbidity and mortality. So that hasn't been the main priority initially. Those data will start to become available during, we think, first quarter.
Okay, seeing no additional questions, I think we'll go ahead and conclude. This has been recorded, so we will be providing this to the health system, CHC, the medical society, to share them as well. If you haven't had a chance to sign up for our listserv on information that comes from both the State Health Department and the CDC, please just get in contact with someone from Scott County Health Department and we will share that there. Thank you, Dr. Katz, for your time, for your attention to this, for sharing this with us, and we look forward to hearing more as more is rolled out. Any final thoughts, Dr. Katz?
No, I consider every doc and every nurse in the community a public health officer. We have a lot of ground to make up because of events that have occurred since last January. And people trust their providers, even if they don't trust Anthony Fauci or they don't trust me. I think the data, assuming no big changes, are very, very clear, and that providers in the community have a responsibility to get behind the appropriate use of this vaccine, which by the time we're in the next late spring and summer means virtually everybody.
Thank you so much. Thank you for joining us, and have a great afternoon.